Good afternoon and welcome. My name is Sherry Miller, and I am a Liberty University student in the School of Behavior Sciences. And today I'm going to be sharing with you some information on a therapy theory called cognitive processing therapy, CPT. Not CBT, but CPT. I will be discussing the nature of this model, who it is for, and what it can treat. Cognitive processing therapy, it is an evidence-based treatment for post-traumatic stress disorder. It is a specific type of cognitive behavior therapy that has been effective in reducing symptoms of PTSD that have developed after experiencing traumatic events, including child abuse, combat, rape, natural disasters, and human trafficking. Although CPT is rooted in cognitive behavior therapy principles, it focuses on the way the client interprets and makes sense of their traumatic experiences. It is a time-limited therapy that can be completed in 12 weeks. CBT operates on the assumption that the thoughts and beliefs that an individual develops about themselves, others, and the world following a traumatic event can contribute to their emotional distress, which can interfere with their ability to recover. Cognitive processing therapy was developed in the late 80s, and at that time it was primarily utilized to treat combat veterans, refugees, and sexual assault victims using some elements of cognitive behavioral therapy to address the trauma. As we know, trauma is a response to an extremely stressful event or situation that causes dysfunction in one's physical and mental well being. With trauma, the body may react unconsciously to memories of negative events that may cause physical symptoms such as headaches, fatigue, and anxiety related symptoms, including racing heart, sweating, and feeling jumpy. But PTSD is a little bit different. One may experience symptoms aforementioned, but PTSD affects thoughts, which affects emotions, which affects behavior. The individual may think the world is unsafe, that they are to blame for what happened, or they avoid going out and expect something negative to happen when they do go out due to stuck points that they have. The thought process in having PTSD will make one jump to negative conclusions. Now, a stuck point is a thought that you have repeatedly that leads to painful emotions that won't go away and can cause stress, anxiety, depression, avoidance. Signs of PTSD includes intrusions, avoidance, and negative alterations in cognitions and mood. CPT can address anything that has the client at a stuck point with memories, fears, avoidance, and it puts the focus on the way the client interprets and makes sense of their traumatic experiences. CBT treatment is strongly recommended for treatment of PTSD, and it is only for individuals that has a current diagnosis. Here's a short overview.
It can be caused by trauma from things like explosions, sexual abuse, natural disasters, and more.
On the outside, you should be feeling safe. You should be okay by now. Put it behind you, forget it. But for those of us who have the PTSD, it's not possible.
Cognitive processing therapy is an evidence-based approach that is considered the gold standard by the VA.
It's premised upon the connection between our thoughts, our emotions, and our behaviors. And if they're working in tandem towards adaptive behavior, it's great.
Lee Health licensed clinical social worker and psychotherapist David Canto says it starts with a patient writing down their story for the clinician so it's less distressing.
So you get that pain-saturated story out, and then the clinician with the patient will sort of identify some of these cognitive errors. And then they start really challenging them.
The goal is to modify and challenge the negative beliefs that the patient has about the trauma.
The emotions pop up and they're negative, and those lead to negative thoughts and negative behaviors, and those reinforce each other. So the premise under that is if you can change one, you change the other two. Basically, you're training yourself I think in a much more titrated way to go to that dark place, but you're using cognition to change your mental experience regarding it.
Lee Health has a fully staffed outpatient behavioral health center for safe and effective therapy. Speak with your doctor if you or a loved one is struggling with PTSD. For Lee Health, I'm Devin Turk.
When assessing someone for the first time to treat them utilizing CPT, as with any other treatment, the therapist will assess for active suicide, ideation, plan, or intent. They will assess for psychotic symptoms and medication compliance, if any. And this is done through self-reporting, which is an adequate assessment. With cognitive processing therapy, the session is conversation based, where the therapist may have the client discuss the trauma in detail or write about it. It is the therapist's responsibility to focus on safety, trust, power, control, esteem, and intimacy, as these are all areas that can be affected by traumatic experiences. The role of the counselor in CPT is an educator, it is directive, asking stimulating questions to foster thought and bring about awareness to thoughts, behaviors, avoidance, and emotions that the client is experiencing. The therapist helps the client make connections with their automatic thoughts and reactions, where the client begins to recognize the automatic thoughts may be supporting their PTSD symptoms. The role of the client is to be engaged and open in discussing in detail the trauma at some point, to consider other ways of thinking about things, and to stop blaming themselves for the event, as this will make therapy much more successful. With CPT, it is not necessary for the therapist to know what the traumatic event was initially, just the feelings associated with it when the client is thinking about it. As the client is engaged in CPT, they become more aware of the relationship between their thoughts and emotions, and they begin to identify automatic thoughts that are keeping them stuck. As time goes on, the client writes impact statements that details current understanding of why traumatic events occurred and how they make sense of the traumatic event. They learn and use skills to challenge negative thoughts and negative conclusions using small changes in thinking, such as the what if question. The client now begins formal processing of the traumas by writing detailed accounts of the worst traumatic experience they've ever had, which they then read in the next therapy session, to try to break the pattern of avoiding thoughts and feelings associated with the trauma in order to modify any maladaptive thinking. So just to recap, the therapist leads, the client learns, and then the client implements. Goals of therapy is for the client to recognize and investigate unhelpful thought patterns, to get out of the stuck point by helping clients change negative conclusions by becoming aware of how the trauma changed them, for clients to learn how to challenge and modify unhelpful beliefs related to the trauma, for clients to create a new understanding and conceptualization of the traumatic event, and that the client will use skills to continue assessing and modifying beliefs related to traumatic events outside of treatment. So to go along with those goals are some healthy coping skills that the client can use outside of treatment on their own. And those would include mindfulness, changing unhealthy thinking, journaling, visualizing, relaxation skills, positive thinking, and interpretation. And again, these are coping skills that it'll help the client feel safer, think rationally, therefore reducing symptoms of PTSD. And using these on their own, I saw an example that I liked. So say you're the client and you're driving, and someone jumps in the lane of traffic in front of you without signaling. You're startled. You become angry. You may curse them. You may promise yourself that you're not coming out again, that you should not have come out. You're telling yourself it's dangerous out here, that the other driver was trying to run you off the road. But if you consider small changes in your thinking before jumping to those conclusions using the what if question, and then you might ask yourself in a different way, what if they were sick and rushing to get to the hospital? Or what if the driver was having a panic attack and was trying to get out of traffic? So a small change like that in thinking can have an impact on how you feel and how you behave. So some critiques I have on cognitive processing therapy, um, that CPT is evidence-based. It's proven successful in treating trauma with veterans and civilians. CPT works well both in individual sessions as well as structured group sessions, as clients will have out-of-session practice assignments to do on their own. CPT showed good gains in Vietnam veterans, but greater gains in Afghanistan and Iraq veterans, primarily due to treating older adults in the age gap. CPT can address anything that has the client at that stuck point. And a few more. It was noticed in early studies that African American women were likely to drop out of treatment, but successful outcomes of treatment were not compared or measured. Other studies show clients tend to drop out of treatment around the 8th week without cause. And most of the research found was based on veterans or those with military sexual trauma. There was also very little information on when to implement CPT. Or say you already have a standing client that's diagnosed with PTSD, when do you start this type of treatment? Now, looking from a Christian worldview, CPT works well with faith and is compatible to a Christian worldview, as the theory currently addresses faith and morale injury and is practiced as a spiritual integrated cognitive processing therapy. It was implemented to target morale injury, which may be a barrier to recovery fully from PTSD, particularly for those who served in combat. However, more research is needed to determine the empirical effectiveness of this approach for individuals who desire a spiritually or religiously integrated treatment for trauma. Now, further research is also needed on the multicultural aspects of CPT, and also there was very little research on treating adolescents. A study on PTSD treatment conducted from 2017 through 2020 with a sample size of 296 married, single, divorced, African American, Caucasian veterans, and other ethnic groups that only represented 4%. That alone causes for further research on the multifaceted aspects of CPT. The most current study found was from 2020 when treating Hispanics relating to immigration trauma. Key points I have here that CPT begins with psychoeducation on PTSD, the relationship with thoughts and emotions and behaviors. A trauma narrative is not required initially. Formal processing of the trauma is where the client writes a detailed account of the worst traumatic experience to try and break the pattern of avoiding thoughts and feelings. Once the client has developed skills to identify and address unhelpful thinking, they will use those thoughts to continue assessing and modifying beliefs related to the traumatic events outside of treatment. And some final takeaways. So CPT is evidence-based practice. It treats diagnosed PTSD. It helps people recover from acute, development, and complex PTSD. It does so faster in 3 months or approximately 12 weeks and with a lower dropout rate than other treatments. And it is the only PTSD treatment that isn't based on exposure therapy. Again, when completing an initial assessment for CPT, it is recommended delaying treatment with clients that have active suicidal ideation, plan, or intent, and for those clients that are psychotic or with full mania and not on medication. There are CPT resources found online, but most online courses, manuals, and trainings were available via Udemy and Pezi and incur a fee. This concludes my presentation on cognitive processing therapy. Thank you for your time and have a great day.